So I'm here with Dr. Sanjeev Nayak at the Royal Stoke University Hospital. And this is the first interview on Let's Fix the NHS, talking about broad healthcare system, but also, of course, about stroke and Dr. Nayak's speciality, thrombectomy. Sanjeev, great to see you.
Great to see you as well.
We didn't actually talk at your conference, did we? But I attended your conference back in September, and I managed to learn quite a lot about your work and about the rest of the work of Ward 127 in the Royal Stoke University Hospital. Following my mum's stroke back in 2023, and her second stroke last year in 2024. And she wasn't a candidate for thrombectomy. She was old and frail, and but thanks to the work of your colleagues, she was able to come home for 10 months, and I was able to spend time and looking after her, and in that late stage, that end stage of her life. But in that time, I was, I'll say, fortunate to learn about your work, the work of your colleagues, but also stroke as an issue globally. And it's shocking. It's scary. But in that time, when Mum was really in her last stages, I came up with the concept of Let's Fix the NHS, which I talked to you about earlier on. You very kindly agreed to meet with me and to highlight the work that you're doing, but also the need to roll out thrombectomy around the country and around the world, and advanced stroke care.
When I was working as a house officer earlier during my career, I used to see stroke patients come to the hospital, and there was not much of a treatment for them. There was not even thrombolysis those days. And patients with severe stroke would come to the hospital and they were kept comfortable, in the sense.
For those who don't know, what's thrombolysis?
Thrombolysis is a treatment which I think came in early 2000, where you would give a clot busting drug. Basically, I'll just explain to you what stroke is. Stroke is when there are two types of stroke. One is when patients bleed into the brain, which is called a hemorrhagic stroke. But the vast majority of the stroke, which is 80%, is because of a clot which forms in one part of the body, either in the heart or somewhere in the extremities or in the neck, which is a carotid artery, and it travels upstream into the brain, into the major vessel of the brain, and occludes it. So basically, it cuts off the blood supply to the brain, and once the blood supply is cut off, that part of the brain infarcts or dies off, and that part of the brain will be responsible for patients' functions such as moving his arm, leg, or their speech, vision. And in severe cases, when it involves the back of the brain, what we call as the basilar artery, it leads to death. Invariably, even in both, if it's a large stroke, it leads to death in a vast majority of the patients if it's not treated. But if it involves the back of the brain, it invariably leads to death. Now, thrombolysis, when I say about thrombolysis, that was a treatment which would help dissolve this clot, and so that the blood flow to the brain is maintained. So basically, it's a bit like putting in, I'll give you simple examples. If you have a small block drain in your house, you put a little bit of drain powder, right, and try to open up the drain. That's thrombolysis for you.
Right.
Okay, now thrombectomy. So thrombectomy is a game-changing treatment. Now, when you have a blocked drain or a big drain blocked, which is outside your house, which is causing the blockage in your house, putting a bit of drain powder is not going to work. Right. So this is where you need a plumber to go in and mechanically open it up. So that's thrombectomy. That's what we do. So now, if you look at the way this stroke is, a vast majority of these patients who have got a large and the most severe stroke, they do not actually, the thrombolysis do not work. The thrombectomy is the treatment which really is game changing. Now, before I come to that, I was just speaking about my background as to why I got interested in this work. So as a house officer, it was acceptable practice in those days. We are talking about late 1990s, and when the treatment of stroke was not that advanced. So it was acceptable to see patients with a large stroke come to the hospital, and hardly any treatment was offered because there's not much treatment, in the sense active treatment, but they were kept comfortable in the sense they were given pain relief, or maybe making sure that they were comfortable from the chest perspective, and eventually they would pass away.
But in some cases they would heal naturally, but rarely.
If somebody has got I'm talking about large stroke. I'm not talking about minor strokes. Minor strokes do heal and get better. Large strokes are associated with mortality in a high percentage of patients.
Right.
And especially if you are an older patient, it's even higher. Younger patients have got a different brain mechanism in the sense they're more resilient.
Right.
So they may get a better outcome. But in the older patients, it's always been when you have a severe stroke, they get a bad outcome. So I'm talking about those patients in those days when I was working as a house officer. These patients would not really make good outcome, and they were accepted to die. Since then, thrombolysis was a treatment came in, which is like a drug which was given in the veins of the patient. It's in a liquid form, but it's quite a potent drug which can burst the clot. But statistic wise, it only worked in 20% or less percentage of patients with a large stroke.
And were there lots of side effects even for the ones that it did work?
Yeah, there were a lot of side effects. They could bleed in some other areas because it was causing blood thinning or causing the clots to burst. It would cause bleeding in areas. It was causing other side effects. So there were side effects, but more so it worked in a very small percentage of patients. So that was what you call the drawback of this treatment. Even though it was a treatment, but it wouldn't be effective in a vast majority of the patients, especially with large vessel occlusion. So then over the time, when I was working as a medical registrar, when I saw this happen and from the SHO, I thought I, I saw a large discrepancy between other treatments and stroke. And stroke was disregarded as something which once you have it, you're written off. If you have a large stroke, you're written off. There's nothing much can be done. But at the same time, I was seeing the development of other specialties like cardiology, which was considered very, in a layman's term, very sexy, because you could open up the vessels. Cardiologists would go in and do something completely, what you call groundbreaking and fine and get patients a good outcome. Even there was advancement in cancer and other areas, but the advancement in stroke wasn't that much because still the treatment wasn't that effective. So time passed on, and as I got into radiology training, and then finally I went to Austria. That was a time there was this groundbreaking treatment for stroke, whereby you could use a stent-like device, which would be placed in a artery where there is occlusion. And um, uh, the good thing about this device was it was made of a material called as nitinol. So when you nitinol. So what happens when you place that stent in a?
Can we go back to who figured out that you could put the stent into the brain through the groin? Where did that?
So basically, in the past there were attempts to do this. As early as 1980s, where there were different kind of devices, but those devices hardly pulled out any clots. So there was not much progress, even though there were devices to pull the clot out, but they didn't give a good outcome to the patient. That's probably because those devices were not effective.
Right.
So what happened in 2009 when I was there in Austria, and around that time, was by accident, when an aneurysm procedure was being performed, a stent was placed in for the aneurysm. Aneurysm is like a blister in the vessel, and you put in coils to block that blister to prevent a bleed in the brain. So a stent was put in, and I understand there was clot formed around the stent. And when the clot was formed around the stent, it was decided to take the stent out because the stent could be pulled out because the stent was
still attached to
the wire.
Right.
Yeah. So that was a new stent, which was it's called a solitaire. So the previous stent would be you put the stent in, the stent wouldn't be attached to a wire. You would just open up in the brain, and that's it. The stent would stay in the brain, and you couldn't take it out. So this was a new stent.
Right.
So the clot was formed around it, and the stent was pulled out and when the stent was pulled out, the clot came out along with it. So they thought, oh, wow, this is something different. If clots can be pulled out the way it is with this stent, so this is something we could do in stroke as well.
That's like a classic Eureka moment, isn't it?
Yes.
It's like when you went home that day, do you remember the realization?
Yes, I mean, we then started writing a paper on this. We started doing, I think, initially when I was there, we did 8 cases, just 8 cases. That was in 3 months.
And you were there observing, training?
I was a fellow. Just before I was a consultant just before I became a consultant, I was as a fellow there towards the end of my career. I mean, my training career. Career. So we started doing few cases out there, maybe 7, 8 cases, and we published them. We were one of the first to publish on this particular device, how it works. And since then, this is something which is what you call pioneering, and people around the Europe and elsewhere started doing the similar kind of procedures where they were using the stent, and it kind of got very quickly across the Europe and across the world. But uh, um, then I came to Stoke-on-Trent, and I discussed this idea with my consultant colleagues here and my team here, and said, look, this is something we could see whether this can work in stroke patients. And if you look at the kind of demographics here in Midlands, you have, especially in this area, you have the socioeconomic status of patients here is not as good as some of the other areas in the country, disadvantaged. And then you also see, along with
I
that,
know, I come from here.
yeah, and you also see, because of that issue, you also see a larger proportion of patients having unhealthy lifestyle, and also
Right.
larger episodes of stroke. And when I came here, we knew from the previous years, there were a large number of patients, a great number of patients dying because of stroke. And even you use this thrombolytic drug, this was a pioneering center for thrombolytic drug even before I came here.
Right, because I understand Ward 127, which was somewhere else at the time, was set up with, was it Indira Natarajan
and Professor Roff,
and Professor Christine Roff,
yeah.
and there were other people involved as well.
Yeah.
But that was the end of that was around about 2000 or just before, wasn't it?
Professor Roff has been here since I think quite a while,
Right.
90s. Indira, I think 2008 or
but they were pioneering in their own right in terms of stroke care, from my understanding.
Yeah, stroke was always this Stoke-on-Trent was always a pioneering center for stroke care.
Right.
And I think they did pioneer use of thrombolytic drug as well. But thrombolytic drug was, like I said, wasn't working in the
It had its limitations.
as its significant limitation. So when I came here, we saw the data, and we saw a large number of patients are actually dying from stroke, not even disability, and large amount who survived were having disability. And this is something that couldn't be addressed by the current treatment. And when I discussed the option of removing the clot by using this device, I think they were absolutely thrilled. And I got to give it to them, because not many physicians would take this approach, because there was no evidence at that time. We all know for every minute you delay, there are millions of brain cells which are at risk. Procedure started from the groin. We actually insert a tube from the groin, and we take it all the way to the main vessels in the neck. And from there we take a very small tube into the brain. Through that tube we place a stent into the clot in the brain, and we then extract the clot by pulling this device out. This is the angiogram of Stuart, and when he came on the main vessels of the brain, there's no flow going there. Following which we went on to use a stent retriever device. 12 minutes later, everything is opened up. We managed to get the clot out and also open up all the vessels in the brain. A very good result from the procedure.
After the operation, I was home the following day. Because as soon as I'd had the operation, it was like just normal, everything worked.
But you had to get it integrated into the hospital system as well.
Yeah.
I mean, I can imagine the risk managers within the trust at the time, were they let's say curious? Were they resistant? Was it difficult?
So I'll put it to you this way. It's very hard to do a new procedure in the National Health Service without being shown there is evidence behind it.
Right.
Okay, so it's literally impossible to get it done. So there were patients who had no option. When we did it, we were doing on a very select group of patients. So the patients who had no option, for example, bacillus stroke, so those patients were treated, and we had some amazing, groundbreaking results. There's one case who came in with intubated, in the sense were tubed and intubated, and had no option for recovery.
So essentially, you're working on someone who is quite literally a corpse. Unless you're able to
revive,
successfully intervene.
So we started working on patients who had no hope. Right. And doing this procedure wouldn't be considered negligent, because those patients were anyway going to die.
So you were giving them a chance.
You're giving them a chance. So when we started doing them giving them a chance procedure, we saw some remarkable results. Patients who were on the verge of death were walking out of the hospital. Some of the patients who were severely disabled were having a great outcome. So this was the start of it. And then the way to deal with this scenario was we needed to get a governance agreement. So initial results were very good. So we started um, writing up a database so that we need to have all the results audited for the purposes of governance.
Mhm.
We took it to the governance and said we are going to do it on select group of patients who got absolutely no hope. So we started doing it very, very selective patients. We didn't offer it to all the patients because it was expensive. Each of the stents are very expensive. The procedure itself is expensive, and there was no evidence behind it.
Right.
So we started doing it on a small group of patients, I would say 20, 30, or maybe maximum 40 a year to start off with.
Were there many? I mean, sometimes when you're creating change, you need champions. And
Yeah.
did you have champions at a high level within the trust? I mean, was this not just a success story of yourself and the stroke colleagues, but leadership
I think
at a hospital level?
I would say the most champions, I would say, are the stroke patients were the champions.
Well,
So
right.
so they were the ones who came forward and sat in our meetings. I think, like I said, Indra and the colleagues were arranging meetings with the commissioners, and
Okay.
the stroke champions, the patients came in and sat in those meetings and started. That's why we engaged the patients, and they were the ones who were saying, "Look, I would have died if not for this procedure."
Where Sanjeev explained to me that where my clot was, he would have given me a 50% chance of survival if I hadn't had a thrombectomy, and an 80% chance of being bedbound for the rest of my life. Now, I was only 48 when it hit, so that's a pretty terrifying thought.
How does that? Does it still affect you? Is it something that's always in the back of your mind? How do you live with knowing what could have been?
Bloody mindedness, I guess. Yeah, I learned to ignore it. I mean, some days I do, get through the day and I forget I've had the stroke, and that's all down to the operation these guys gave me. I got an 8 when my son was 8 when the stroke happened, and that was my biggest fear. How am I going to be a good dad for him? But he's been my biggest inspiration in recovery. I mean, I was discharged. Mine wasn't a light bulb moment getting after the thrombectomy, unfortunately. I've still got left-sided deficit, but I'm making improvements every week at the moment, and I'm 3 years.
So when I got the headache, I thought it was actually hay fever because I get a headache from it. So I took the paracetamol, but then I couldn't see. So I was thinking there's something wrong, and then obviously everything went numb. And then I got the pins and needles, and that's when I collapsed. And then I actually said to the ambulance crew, I said, I think I'm having a stroke. And they actually replied saying, you're too young for a stroke, which actually delayed me getting the thrombectomy sooner, which has led to me having the nerve damage that I've got now.
So talk us through the nerve damage. How are you? How has your recovery been?
So I still have pins and needles everywhere. I can't feel my hand, my foot, my leg, but I've learned how to manage that. So I've learned how to walk with it because I was in a wheelchair, and then I had the walking stick, and then now I'm walking independently. I have to concentrate though because if I don't, I fall over.
Well, first, I'd like to say massive thank you to Dr. Nayak and the team. I'm so grateful to be alive today. And how did I manage to have a stroke? We don't know. But I normally get up like 6:45 in the mornings for my son to get ready for school. And I opened my eyes and I couldn't move. I couldn't speak. But what comes to my mind was the first thing, I'm having a stroke. And so I could make only sounds. And the sounds alerted my son to come to me. And when he did, he didn't understand what was happening. And I wrote, I'm having a stroke. And we tried to get to the floor to see if I could move. I think that was the worst thing. Because in my mind, if I get to the floor, then I can perhaps get up. Actually, it didn't work. I was just lying there, and next thing I was all soaked wet. He rang for the paramedic and my friend. I got to New Cross, but I guess the resources wasn't there, and so they telephoned Stoke. I remember the BBC, was there, and a massive crowd, and everyone lining up and taking photos and videoing. And I remember I was told to count some numbers, and next thing I woke up in the recovery room. I remember one of the nurses said to me when I looked over and saw another patient, and suddenly she wasn't there anymore. I was told she didn't make it. And so I realized how difficult a stroke can be. Today, I'm still affected by the stroke. I do have some neurological defects that I do struggle with on a daily basis. And I would like to say that only a stroke survivor know what stroke really is. And I wouldn't wish that for anyone. It really changes life. So again, I do want to say I am so grateful to be alive today. And I hope that the work that you're doing with the team as well, that it will do a great deal for loads of other patients today. Thank you so much again once more.
So all I wanted to say is that thrombectomy, I feel, gave me 99% of the life that I had before I had a stroke. Thrombectomy, to me, needs to be offered to everybody that should be having the operation across the whole UK, all across the world, to be honest. Yeah, I just think it's just massive, isn't it? I mean, when I think about what it's done to me and the life it's given me back, yeah, 100% everyone needs to have the operation if they can.
Of course, people were questioning, why are we doing such expensive procedure?
Right.
Why? What is the requirement to spend so much of money on this procedure? But if you look at the way we justify it is, it may be expensive, but the amount of time you're giving back for this patient, they will be productive and they can be effective for the society. And more than that, you're saving a life.
I mean, one of the things that, perhaps not today, but at some point I really want to get into is looking at the total economics of stroke. Because when you realize that people might have 20, 30, 40 years in work, that literally they cannot function because it's not just about give them a thrombectomy. It's actually give it within a time frame that is minimizing any potential disability and giving them the greatest function back, isn't there?
Yeah, that's true. And also, there's another thing you need to understand, Steve. I think there's already a document from the Stroke Association. If you roll out thrombectomy throughout the UK or England, I think, you will save 1.3 billion pounds over the next 5 years.
Right.
Saving to the healthcare system. So that's quite a large amount of savings. So there is no. I want to put another perspective about thrombectomy. If you compare it with other treatments, if you compare it with, say, somebody having a heart attack and having a PCI, and
PCI
is coronary intervention.
Okay.
So someone having another form of surgery, the number of patients who you require to treat, or we use NNT as a term, is around, the effect of thrombectomy is probably 10 to 20 times more than somebody having treatment for the heart attack or having some other surgery in similar line. If you use NNT, it's around 26 to 30 for a cardiac patient compared to 2.5 for a stroke patient having thrombectomy.
So if I understand this, so let's say it's 30.
Yeah.
So you've got to treat 30 patients to have one positive outcome.
One positive outcome, yes.
Positive outcome meaning they survive.
They survive and have a good outcome, like being independent and alive.
Right.
Yeah.
So
So in stroke, independent and alive is 2.5.
That's incredible.
Yeah. So that's why they say, it's been said by one of the top health leaders that this is the most innovative treatment of last 50 years.
And I think it was Mr. Powis, wasn't it?
Yeah.
Your event was I think he's the
National Medical Director for NHS England.
Now, when I look back over my 40 years in the NHS, and again, as you've heard, stroke is one of those conditions that has really changed in terms of what we can do for stroke. Back in the 1980s, when I first started practicing, if you had a stroke, pretty much it was around supportive care and then rehabilitation. And of course, in the years since then, we've seen a number of effective treatments being identified and implemented: thrombolysis, drugs to thin the clot, and now more recently mechanical thrombectomy to actually fish the clot out, as you saw in the video, from the vessels where a blood clot has got lodged in the brain and is causing the lack of oxygen to brain tissue and therefore a stroke. And those are fantastic achievements. And I've said thrombectomy is an intervention that has been identified over the last couple of decades as a highly effective intervention. Again, as you've heard, it's one of the most effective clinical interventions that we have in medicine. And it's transformative for those who have suffered a stroke, but also for those who are undertaking the thrombectomy, to see somebody come in with a severe disability and then shortly after the procedure, that disability has recovered. And to see somebody with that sort of severe disability be able to walk out of hospital, as often happens a day or two later, is really remarkable. And I think it's fair to say that when it comes to thrombectomy and stroke management, the team here at Stoke are becoming legends in their own right amongst the stroke communities.
Yeah, which is some accolade. And going back to that number that the Stroke Association, about that 1.2, 1.3 billion. Personally, I think it's lowballing what the actual benefit to society, and there's an economic cost, then there's the human cost. And if I remember rightly, it's about 120,000 stroke patients a year. Is that correct?
That's the total number of stroke patients. I think the patients who could benefit, even if you put, they're saying around 10 to 15% of large vessel occlusion. That's based on data which is 6 hours. If you include up to 24 hours, which is the use of AI,
right,
you're looking at the numbers from 10,000 annually who can benefit from thrombectomy to 15 to 20 or maybe even 30,000.
Right.
Because you're looking at other broader options now. It doesn't limit to large vessels, but also you can use medium vessel occlusions as well for thrombectomy.
So from the stroke perspective, the occlusion, it can be in smaller vessels. It's not only in the major vessels.
For example, some patients have got medium vessels. When I say medium, you have the branching of the main vessel in the brain, the middle cerebral artery.
Kind of like a tree, right?
Like a tree, yeah.
Yeah.
So if it's not just the main trunk of the tree, the other branches, if you occlude some of the other branches, if those branches are supplying to that part of the brain which is vital for function, for example, arm, leg, or speech,
right,
so that even that small branch, it's not a small branch, but it's a medium to branch, is very vital. So you can even reach for those vessels and give them a good outcome. So why limit this treatment to just the major trunk of the tree? You can limit it to elsewhere.
So that can happen, meaning you see commonly that people have clots in places that you can't get to, or you couldn't previously get to, but you can now. Essentially,
I mean, we are doing it here.
Right.
I mean, it's not, again, this is again gray area for evidence, but we always stayed well ahead of evidence, and we are treating patients with medium or smaller vessel occlusions, and we have got very good results. And I think if we follow, because that's the reason, if you look at the number of patients we treat here, we are well above the national average of 15% or 10 to 15. That's the reason is we are treating all eligible patients.
Right.
And we are not looking at, we look at the patients from a symptom perspective. You look at
the national, the goal is 10 to 15%, isn't it? But
yeah,
the national average is like 3 or 4 or something.
The national average is
way above it.
4.2%.
Right.
Last year, I think.
Right. So if we go back to those numbers, I mean, we talked about it previously, and it's hard, to get an exact number, but if the country, if it's, let's say it's 15,000,
yeah,
and there's about 5,000 currently, I understand, operated who have a thrombectomy, that 10,000, how many of them typically would die, and how many would survive without the thrombectomy?
So let's say if someone's have a large vessel occlusion and without treatment, it's a high risk, 50% risk of mortality. I would say 5,000 could possibly die. I'm not saying I can't be 100% sure, but that's the kind of risk you're looking at.
Right. And if we go to the permanent disability, I've seen a number of people who have struggle walking, who are in wheelchairs. It's right, isn't it, that if you have a right-sided stroke, your left side is going to be affected, and the other way around. But the effects on those people, young or old, is horrendous. And when you add in the cost of care, the emotional trauma on family and on the patient, for those who survive, obviously for those who who pass, it's different again. But the cost, when you actually really get into it, it is massive on society. And for me, my outrage, and it really is outrage, is you have pioneered a procedure which has continued to advance. Others have taken it on, and I think there's 24, 25 centres in the UK that do it, right?
Yes.
But that's still only 25%-ish of the total need. And if we go to 100%, the holy grail would be anyone who needs it, wherever they have a stroke, can get it. And then they have advanced stroke care, both in hospital, in rehab, and in the community thereafter. So, but if we just take a thrombectomy, what we're saying is essentially 75% of the country, this postcode lottery, or call it 70% if we want to be generous, they cannot have what you can do here in Stoke-on-Trent.
Yes, I mean there's a huge issue of postcode lottery. I like to put it in simple terms. Like we just now mentioned about 5 to 10,000 patients who could either die or have a disability, right? So either let's say if this was not stroke and something else, if 5 to 10,000 patients or people are dying in the country or having a disability because of some reason, there would be a huge, what do you call, uproar. And also this would be a scandal, right? When it comes to a health issue and somebody is dying, that doesn't become a scandal. You see what I mean? So if we had people dying because of some other reason, 5 or 10,000 patients, that could have been a huge issue, especially when you can prevent them.
So what's your, and this is not new. I mean, at your event, the journalist from The Guardian talked about writing an article in 2016. And, it's not like we're just discovering it today in 2024, that this is, the closest thing to a miracle procedure you could probably get. And yet, why? All these years, what's missing? At the Royal Stoke, the central government or the NHS England have allocated for the capital equipment costs of a second theatre.
The capital cost is around 1.2 million.
Oh, okay.
Yeah, but I think there are other costs which are enabling costs. So that's the issue where you need funds for that. It's a work in progress. But you see, from the issue here is from 40 patients in 2009 to nearly 300 patients now, we still have one theatre using the same room, and that's not changed. So this is the recovery area here.
Sanjeev, explain where we are now.
Okay, this is our interventional suite. This is where we do our procedures for stroke patients, the thrombectomy procedures. So you're walking into the main area. We have got a couple of theatres. This one here is the main theatre where we do where we operate on these patients. As you can see, this is the area where we do the scrub. We scrub for the procedure. And this room here is the anesthetic room where we put the patients to sleep. As you walk in here, this is the main interventional suite. As you can see, this room here, we got two equipment. This is the biplane angiographic suite. This is state of art. We can do a variety of neurovascular procedures here, but we use this particular room for performing thrombectomy procedures for the patients.
And would you explain what a biplane is?
Yeah, it's basically you have an equipment where you have two arms. It's like a robotic arms. We can look at two different planes of the brain, one from top to bottom and one from side to side. So it rotates around the patient, and we can look at the brain from different angles and different views.
What about the screens and the scans?
These are the big screens where we can look at those patients and actually make images of the patients as we do the procedure. It's a live active screening where we can see what we are doing as we do the procedures, and you can also view them in the room at the back.
And typically, how long does it take?
Procedure can vary. Sometimes it can take a few minutes, and sometimes it can take a few hours. So depending on the complexity of the case.
Right. And you plan in detail beforehand. You know what you're going to do.
We know what we are doing because we have the AI and the imaging software beforehand. We know what exactly happens especially with the stroke patients, and we do the planning beforehand, and then they come here for the procedure.
And how many people would be in here when you're actually, do you call it an operation or a procedure?
Yeah, it's an operation. Yeah.
Right, okay.
So we have myself as the operator, we have a couple of nurses, we have a radiographer who will maneuver this equipment and then we have an anesthetist and an anesthetic assistant as well.
That literally is the only room you've done this
Yeah.
in.
So
That's been your home since
yeah.
2009.
So don't you
Okay.
think after moving from maybe not in 40, I would say from 20, 30 patients
Right.
to now more around 300 patients, and you're looking at in the future now, okay? In the future, we are looking at treating more patients in the region. So that number would be around 500.
And we're going to, hopefully Ryan and Josh from the paramedics are going
Yeah.
to sit down and do a similar interview to show me what they're doing, show everybody what they're doing in terms of getting people to the right centre, because typically what can happen is an ambulance driver or paramedic would go to the closest available facility, but sometimes that's not the facility with thrombectomy capability, and therefore they're trialing all manner of process and training capability so that people can have video triage initially, and they can also go directly bypassing the closest centre to the centre with the thrombectomy capability. But can we go back to the theatre? So that one theatre, is it dedicated for thrombectomy?
No. Even that one theatre which we have, there are other procedures which are being performed there.
Right,
So
okay.
it's, you know,
So
one idea.
what else gets done in that theatre?
So we do other neurovascular procedures like brain aneurysms, spinal work, and other vascular brain, and also it's used by vascular radiologists to do body work.
Okay.
So like aortic aneurysm, peripheral limb. So there's a lot of procedures going on. It's running throughout the day and also out of hours.
So if someone's had a stroke,
Yeah.
and we know time is brain,
Yeah.
this is the great. What happens if the theatre's in use?
The patients just wait, and sometimes they can have a bad outcome because they're just waiting for the theatre to be available for them.
So let's say you get your additional theatre, which means, okay, so the money that's been allocated for the capital equipment, we need money allocated locally to build it into the system.
Yeah.
So that, what does that take practically to build it into the system?
No, it's a room with a theatre facility.
Right.
And also this equipment is expensive, and it's like it has to be embedded into the room with anesthetic facilities. And so let me put it to you, we may need not one additional, we may need two, looking at future, because now we're already in a stage where we need two.
Right.
So that's going to be full of capacity once we start accepting more patients for stroke. And then we're looking at not very far from now, another 5 years, now from 300 we may go to 500 number of patients. So even the second theatre would be just not enough. So it'll be the third one. So
and what about the human capital side of things? And we're just talking about Stoke now. We'll go back to that, countrywide 100% coverage, holy grail.
So these are the issues. These are the problems which needs to be looked into. Yeah.
Right.
So if we are talking about this is just the one side of the issue. When you asked me that question previously, why is it that we don't have a 24/7 service? And I know there's a lot of talk about there's not enough people doing it. I don't think so. That's accurate. It's not just one issue. There's several issues. One of them is just maybe the issue which I mentioned about the theatre space. Now, even if you build 2 or 3 theatres, you need staff for them. You need nurses, you need radiographers, you need anesthetists. So where are they going to come from? So you need enough money to get the additional staffing as well. And then you have other issues. You don't have not just the doctors, also the people doing the procedure, but the people who refer to the procedure.
They're the stroke consultants.
The stroke consultants. So we already know there is a shortage of stroke consultants across the country. So there's some remote areas where we don't have stroke consultants at all. So someone who's had a stroke, so that's even worse than the thrombectomy postcode lottery. They don't even get treated properly for their stroke. So those things are also needs to be urgently addressed. And what about the other issues of the transfer issues, the patients coming to the hospital? Already we know from the SNAP data there's a delay of 45 minutes from last year for patients even to call the ambulance and to come to the hospital. Despite the campaigns which has been done, the fast campaigns.
Yeah.
There's a delay for the patients to even call the ambulance, and there's a delay of 45 minutes even before the ambulance comes to the patient. Despite we need to have a further campaign, some form of a campaign to increase awareness. The stroke is something you can't sit on it. You need to come to the hospital. Otherwise, if you sit on it, you're just going to get a bad outcome. Second point is how even get from point home to the hospital. We have delays in the ambulance transferring the patients.
Which is what we talked about before is, I mean, first of all, we know the ambulance service is under massive pressure.
Yeah.
They queue at the, and have to stay with the patient. So
Yeah.
in the case of stroke, is that different currently? Meaning, are they able to fast track a stroke patient or a suspected stroke
No,
patient?
no, stroke patients are supposed to be fast tracked. It's category 2 still for stroke patient. I think it's now being moved to category 1 but I think still there is talks around it.
Category 1 meaning heart attack or
heart attack, patients with cardiac arrest, and patients who are urgent, immediate risk of life. So, but stroke, the problem is that it's not about the immediate risk, but the time is so critical in strokes. You can get an excellent outcome if you come to the hospital. So that has to change.
We've established there's an awful lot of factors. It's a systems problem.
Yeah,
is what I term it.
It's a huge problem within the system. It's not one. You can't pinpoint it to either lack of doctors or lack of people doing it, or that's
right.
In my view, if you say that, it's just scapegoating the issue to kind of deflect the problem from the wider issue. Yeah,
right.
So,
and the goal is, if you think of, I mean, you use multidisciplinary teams within the hospital environment and within the healthcare environment. And one of the things that your event in September, as well as the ISDN event that happened just a few weeks ago, which you were here operating at the time, so you couldn't attend.
Yeah.
But there was probably 100 people from. For those who don't know, ISDNs are Integrated Stroke Delivery Network, and the challenge is they currently fall under NHS England, which we know is potentially going to be abolished. So we have to hope that the ISDNs are this continuation, and the NHS under central government is able to keep those aspects, because they pull together people important. But I think what's required is some sort of systems planning workshop that are able to look at all of these factors on a national level. Because I think in your event, I was trying to say, is there a number it would to provide 100% coverage around the country?
When you say number,
500 million.
Oh, this
1 billion.
Well, it's. I think the figure was 400 million.
Right.
So if you spend in 400 million, you could possibly save 1.3 billion.
So so we're talking about the cost of getting 100% coverage. You talked about 400 million invested will save 1.3 billion.
Yeah.
I'd love to know how we could break that down and really understand what that number is, because both numbers, because to me, let's just sort of go back a bit. It's 3,000 to 5,000 lives annually, and it's probably double that at least in people who are permanently disabled as a result of the time taken to get thrombectomy or to have appropriate treatment, thrombolysis. Or not getting it at all. That's 70% of the country that can't get it. So I would love to see, if there was one, a master plan of how within 5 years the country could have 100% coverage for thrombectomy, and some sort of estimate as to how to cost that. Because again, there's ambulance and paramedic training, there's the radiologist, there's the nurse. I mean, there is, if you were to say, a new centre requires X, Y, and Z. Obviously, theatre and theatre redundant. That would be my goal, to try and understand
there is sorry to interrupt you, Steve.
No. I love it.
So basically, there is no one size fits all. There's nothing.
Right.
There's no master plan. It has to be catered to every individual requirement. So, for example, our centre may need another theatre or 2 theatres to deal with it. Some other centre may need more staff. Some other centre, for example, in east of Anglia, there are issues with transfers because of the distance. So those issues has to be addressed. So every region will be different,
right?
And every requirement will be different. Some areas they may not have doctors. So those areas has
doctors. You mean stroke consultants,
stroke physicians, or even other specialities which are involved in stroke care. Also anesthetists and the doctors performing the procedure itself. I'm not saying that that those are the main issues, but those are within the problem. Depending on each region, what's important for that region, how are you going to address that issue?
Right.
Even if you get a perfectly well-designed thrombectomy center there, you may not have the facility to get the patients there.
Right. But,
for example,
helicopter, can that
exactly, that's what I was talking about. If the government can invest in air ambulances for these patients and can get to those centers quickly, because the way the geography is located for these 24 centers which are performing thrombectomy, even if you have air ambulances, you can get them quicker from, if one center isn't accepting, you can take them to a center which has got capacity.
Right, of course.
So that's a kind of
like they do New Cross to here and stuff like that.
Yes, I mean, we have patients being airlifted, but if you look at the data nationally, it's around 1% of the patients are being airlifted. Compared in our center, it's still not huge. It's only 4.5% or something.
Right.
Still, it's a small number. If you get majority of these patients airlifted, you can give them a better outcome. So this is just one facet of the problem.
Right.
We can have several. This is where I see there's several facets. So what can be done is get these individual sent to have a discussion about what their requirements are. The bottom line is we need funding.
Exactly.
The money should be then given to them according to what they require for.
Just to be clear, I'm not saying there needs to be it's not like there's a box and you put that box into every place. Of course, it's tailored and individual to a regional need based upon the staffing levels already. They're based on their geography. There's so many factors, but in a way, what we need to create, there should be a national master plan which essentially integrates regional plans that are tailored to that particular region. And are you saying that does not exist?
No, I don't think so. That doesn't exist. There are what you call satellite plans to improve staffing, the satellite plan to increase training. There's nothing as a holistic approach to see how we can deal with it depending on what's required. So that's the kind of approach you need to take.
Yeah.
If that doesn't happen, then I don't see how, the best of the intention, things may not work out the way it should work out until you really address every single facet of the problem. And not only the funding is important, also ring fencing the money is important. If you look at NHS, the way it works is if you give them a certain amount of money to deliver a service, they may have other priorities. So that money can completely go into other services. So
do you remember your event? There was someone from Bristol.
Dr. Scott's one of the consultant INRs from Bristol. It's tremendous day, Sanjeev, absolutely wonderful. You've covered pretty much absolutely everything. And the patients, I was in tears. And I did 82 thrombectomies last year and still made me cry. And we've come to the end of the day and here we are for the nuts and bolts of it. We'd say we don't have enough money and we're not getting enough investment, but then on the other hand, we're saying we get £13,000 of tariff for each thrombectomy. So, but this day has been so comprehensive. We've heard of absolutely everything in the pathway that could possibly be discussed, but there's an X factor going on in this equation which doesn't quite add up what's going on. And for me, I'm clinical director of the radiology department in Bristol. And I can say that tariff, so that money each time you do a thrombectomy, you're absolutely right. It's basic business, right? So if you grow, there's price times revenue. And if you want to continue growing, you invest that money and you grow the business. It never finds its way back to that service, ever. And it's plugging holes. And I think are there any medical directors in the room? That's a problem. There was this morning. And I think if you look at services that are well led, best as they can be, Stoke, we had the Walton guys here earlier. I don't know if they've left. Another very good centre. You usually have a medical director who gets it because they have to marry up the information that was given to us by the paramedics, the only person who all day has mentioned number needed to treat. It's got a number needed to treat, which is as good as penicillin, almost. Number needed to treat for PCI is 18. That's almost happening by chance. So it's extraordinarily effective. So for me, what's missing today from this room, from this discussion, because Prof. Powis and the team nationally can only influence East Trust. Once they've influenced it from a NHS England point of view, it's up to the Trust medical director and team to decide where the
the limited resources, because it's on opportunity cost, goes. And we've already heard, the Labour government saying there's no more money without reform. So God knows I wouldn't want really to be a medical director, because it's an extraordinarily difficult job because you have no money. And you've got, we've heard from our anaesthetic colleague here how stressed everything is. Newborn babies in pain with needing their hip and everything. So it's about trying to, but someone somewhere needs to say, okay, everything is important, but thrombectomy is more important than others. And that money needs to be, we need to follow that money and reinvest it in thrombectomy services. I think that's the critical thing.
We had a good chat afterwards, and he was saying that I think it was between £13,000 and £15,000 is allocated for a thrombectomy. And what he mentioned was the medical director, when they perform the thrombectomy, that should be ring-fenced in theory. But what happens is that money is paid down through central government or through NHS. I don't quite know the flow of money, but essentially that 13,000 or 15,000 then is used by the medical directors for other procedures and other expenditure.
Yeah, that's how.
Is that typical?
That's very typical. The money which comes into the service we really don't see that money. We don't know where that money goes. If you look at our center, if you're doing 300 thrombectomies, we should be having a lot of money, but we don't. We don't even know where that money is going. So that's going to other services or other areas. We don't know where
So for an outsider like me,
yeah,
just help me understand. So you've got theatres, you've got non-related staff, cleaning, you've got essentially it's a total budget, is it?
It's different. It's not. We are talking two separate issues here. One is how the funding is not per case. This is the funding per case which comes in.
Right.
It's a totally different issue, which the hospital gets for doing a single procedure. It's not 15. I think it's around 10 to 12,000 pounds, something like that. So that money comes in, is paid by the commissioning groups into the hospital. Right. So that money comes to the hospital because of the procedures you have done. Now, that's a separate issue. That even that money which comes in, nobody knows, or I don't know, or the department, it doesn't come to the department, doesn't come to the getting more nurses or no more staff. It goes into the hospital budget, and they will use it the way they feel is most appropriate. And for the hospital, there may be other pressing issues, which may be the waiting times in the A&E or so many other issues which may be very important. So they may be using it according to that perspective. So it may not be used for thrombectomy at all. So this is a separate issue.
And one can understand that because the population, broadly has got, differing needs. But in a way, if you're earning, you should have at least some recognition for the work that you're doing. You need to reinvest, right? You're spending money on capital equipment, you're spending money on consumables. I'm sure your stents are not inexpensive. So how does it work from a budgeting perspective? If you all of a sudden have got to have a new form of catheter or whatever, how do you...
We do get that budgeting thing. So catheter is not an issue.
Right.
Or the equipment. I know what you're saying.
Yeah.
But the issue is that money should be invested into getting more staff for us, more of to improve the patient experience. We need another theatre maybe, or other in-hospital processes which can make this procedure quicker. Maybe getting more AI-based, software, or maybe for other peripheral hospitals as well. And that's not how it works. But that's a separate issue. But even what I'm trying to emphasize here is even with that money, it won't be enough to develop a proper service. When I say proper service, to get it 100% coverage, that money won't be enough. So there should be when the cardiology services came up in this country, they had this pump priming fund, and capital investment was done into the service, and which allowed them to develop more theatres, more of staff and everything. It was like, I think 400 million was put in. So that's what we require for thrombectomy.
And when you think about it, we go back to that 5,000, 4,000 to 5,000 lives. That's 1 September 11th every single year. 1 September the 11th of deaths.
Stroke
Prevent. Some of them are quickly, within 24 hours, right? And some might take months, but and that is a point. How many people will survive? What's the sort of progressive mortality rate. So people, they might survive 3 months, 6 months, 6 years, or 6 days.
Yeah, it varies, but either ways, with large vessel stroke, it's even if they survive, the quality of life is not great. It's imagine being bedbound, requiring carers all the time, being in a social, nursing home, and those things also have to be looked into, has to be taken into consideration. The costs with this are huge, as we discussed.
So my point is 400 million. Even if it was 400 million annually for 5 years, it's still going to be saving society, 30,000 people who will be alive.
Absolutely.
That would not be.
Absolutely. This is no brainer. I mean, I feel very passionate about this. There's no brainer with this treatment. It's going to be a game changer. There should be means that every single center in the UK or every single place in the UK should have what you call access to this treatment.
So just talk, to finish off, what do you, other than money coming in and the message going out, awareness, I mean, in order to train, is there enough training capacity for the people who are physically doing the operation? I mean, is that...
We are setting up a training facility now through our university using cadavers. So, I mean, that's...
Here.
In Kiel, yeah. And that's something in progress at the moment. And I think probably we're the first center to do it in England. So
right. So how do people train as it is right now? Because if you need more of them, you need more to recognize early on in their career, their medical career, how exciting this is, how important it is, and how rewarding. I mean, you're literally bringing people to life every day.
Like I said before, training is just one part of this issue. That's one facet of this problem. There are several facets which I mentioned. The other staffing, which is also deficient. Also, like I mentioned, there are issues with the pathway, the patients getting in the hospital quicker.
Right.
All those things have to be addressed. You can't focus on one issue. If the message across, which I'm trying to, give the message to whoever is listening, is the entire system should be revamped in a way that the system becomes sleeker for the patients to come into the hospital. They get treatment quicker, and also we have facilities to perform this treatment. So it's the holistic approach rather than just looking at one.
Right.
I think I would be very concerned. I won't say use the term concern. I would think it's a wrong way to look at one part of look at this as a one single problem. This is, if we improve this is going to get better. It's not going to work that way. It has to be looking at the whole issue as holistically.
Yeah.
And then try and see how we can address this as a holistic issue. If you try to get single-minded and focus on one issue, you'll miss the other.
To be clear, I recognize that this is it is a pathway, isn't it? We have to have very, very fast diagnosis. People referring in the minute there's a droop of the face or of the arm or any of the symptoms, and people need mass awareness. But if you look at that recognition initially and suspected stroke, right the way through to video triage, right the way through the best intervention possible for the individual. And then you have people coming out the other side who go into Ward 127 or go into the Hayward, and then they go home. And we need revolution all the way through, but it's got to be connected.
Yeah.
And that's what I care about, looking at that total systems approach.
I think what we need is more people like yourselves. This is where it's important that we raise this awareness. The more people talk about it, the more people hear about it. So more politicians will hear about this. That's why we need to get talking. We need to keep making awareness about this, saying that, look, this is something which is groundbreaking, can change lives, and still it's lacking. And the way I think the mindset should change. At the moment, there's a mindset which is kind of not that positive when we talk about stroke compared to some of the other treatments. There's a lot of hype around, I won't name the treatments, you know what they are. So we need to change the mindset. Why do you call it stroke? Call it brain attack, like the way you call heart attack. Say brain attack. That makes it more powerful. You should change the way things are described.
It's interesting. I mean, stroke as a term, it's used in humour. There are more than a few jokes about stroke, and it does sound nicer than it is. But you're right. In a way, that whole branding issue.
Yeah.
Someone I know is called Rory Sutherland. I told him about Let's Fix the
Mm.
NHS. He said this is quite a good idea, but he's the vice chairman of Ogilvy and he's the head of their behavioral sciences
Mm.
group. Google him on YouTube, you'll see him all over the place. And he's a genius in perception management and branding and everything
Mm.
ad agency related. But the behavioral sciences of this are
Mm.
very, very important.
Mm.
So maybe we could bring Rory in and he can give his expertise, because for sure, until it happened to me,
Yeah.
well, my mum, I didn't know that much about stroke. I'll be honest. I
Mm.
knew a little bit. I knew it was not great, or the potential of it, and I knew it was increasingly common. But when you really understand
Mm.
how it affects everybody, family, friends,
Yeah.
the patient, and people die, the effort to get back to normal life, and in many cases it's not possible.
Mm.
It's just such a burden on society.
Mm.
And what you're doing, Sanjeev, is just commendable, that you don't care just about going and doing your job, as exciting as it is. You care about the broader system and how we can give this life-saving treatment. Where's the best in the world? Let's say it's Stoke, but aside from Stoke, what centres around the world are doing amazing stroke-related treatment, thrombectomy, thrombolysis? What, in your view, is the gold standard?
I think the term gold standard isn't there, but I think there's a lot of centers doing good work. London is doing good work.
Okay.
Okay, so London's got good coverage for thrombectomy.
The Royal London, or the St.
London's got a
Bart's,
they got a network. Royal London, St. George's, and they got a network of hospitals where patients do get treatment. And that's the point here is they because it's capital, there's a lot of investment there. So London has got a lot of investment for stroke itself. So that's why they are doing really well, and that's the kind of investment is required elsewhere as well in the country, not just in the capital. Of course, in Europe, if you look at Germany, is doing really well.
Okay.
Germany has been doing well for a long time. It's been, when UK wasn't doing thrombectomy, they were still ahead of curve, way back. So Germany is doing really well, and some places in the US. So it's patchy. If you look at the map, if you look at the thrombectomy map, it's very patchy.
I mean, India, it's one of the biggest killers, isn't it?
Yeah, India, it's Southeast Asia, it's still very poor. The coverage is very poor. India has got, very poor coverage for thrombectomy. Same goes with, I think, China and that part of the world, Southeast Asia. I think Japan is pretty good, okay, with thrombectomy. So it hit and miss again. But I think what's most important is all these countries we just spoke about, they know that they're trying their best. There are people around there, people who are championing this. People know this is something they need to work on, and there's a lot of work going around at the moment. People are really focused on getting this treatment done across the world.
I mean, the UK, could this not be an export, this knowledge and understanding? Could we not create, we're talking about cost, but surely if the benefits are there, we could on a national basis create really incredible training and education facilities.
Yes, I agree with that.
To look at it as, could it bring revenue to help offset some of that additional cost, even though we're offsetting the cost through the economic benefit of getting people back into work and have quality lives. But so there's an export side to this, isn't there? This knowledge, this understanding, and putting it into systems.
I think before we go for the export side, we should first sort out the problems here and make sure we have a 24/7 coverage. And then, of course, we can think of marketing it to other places, other countries as well.
But in a way, this is a political thing. We want to get people on board in a way that they need to hear it and need to understand it. And a lot of people will hear cost, the political types. And we need really to raise the awareness on the problem. But what is the opportunity? So it's the problem, the solution, and that opportunity as well. So don't get me wrong. I think we have to sort around.
I completely get it. Maybe that's an excellent idea. Getting in revenue through training from other countries. That's something brilliant. I mean, that's something, it can't be done at a local level. This has to be having the support from the higher ups in the Department of Health. There is capacity to do it. There's opportunity, and there's a huge business opportunity for for the healthcare system as well, by saying that we can provide the training, comprehensive training, and where we can get revenue in as well.
And from the suppliers and medtech and innovation, just to wrap this up, because this has been amazing, and I really do appreciate it. I feel guilty actually taking your time away when you could be, there. With stroke, I guess you have to operate when you've got to operate. We know that if there's a call, you got to go. But what's coming down the line in terms of innovation, in terms of, and those suppliers that are part of it? You must have do you have a network of suppliers that are heavily involved in your planning and in your, in the procedures? I mean, how does that work?
Innovation is constantly happening from the devices we used way back in those days, and now it's completely changed. The better devices, but more than that, the innovation is in AI. We've been using AI, and we have, when we initially started, we would treat patients only up to 4 or 6 hours. Now we can treat beyond 24 hours and even sometimes beyond, based on AI. So larger number of patients are benefiting.
So essentially, it's using the AI to interpret the scans.
Scans of the brain, and scans of the brain in different way. What we call is a perfusion scanning, whereby we can see how much of the brain is still. The concept of time is out of the window now. It's about how much of the brain can be salvaged, how much of it can be saved.
So time was a crude measurement. So within 4 hours or within 9 hours or whatever.
Yeah, it was 4 hours for thrombolysis, 4.5 hours, but that was based on studies when there was no AI.
Right.
Now we have artificial intelligence. We have means to measure how much of brain is impacted. We don't need a crude measure to give us idea about when we should be treating, but we should look at real time. How's this patient now? The patient has got X amount of brain which can be salvaged, or this patient has already got brain which cannot be salvaged. Based on that information, we can then give the directed treatment.
Amazing. Well, we'll call it a day.
Yes.
Thank you so much.
Thank you. It was nice talking to you as well.
Okay, so we've had an amazing discussion with Sanjeev, and the work that is being done here at the Royal Stoke is truly groundbreaking. But we need to have it all throughout the country and ultimately all around the world. And stroke doesn't have to be a death sentence. The treatment can give people the opportunity for full lives, quality lives, and that is what we want for as many people as possible. And that's what I'm going to be working for on behalf of Let's Fix the NHS and with Let's Fix the NHS as a platform. But we want to recognise just amazing work that's been done, and we need more of it. So Sanjeev, to you, just for your final words, your thought.
Well, Steve, as I would say, we've been doing this for a long time. Wish you good luck. We need people like you to come on board, and we need more individuals like yourself to raise awareness. So I hope you fix the NHS. I wish good luck for it, and I hope you are able to make a change.
Thank you. Thanks.